Next up, we have Jean-Nicolas. I think he goes by JN. So I'll let him introduce himself better than I could. Thank you so much for being here. We look forward to hearing from you.
Thank you for having me. Also can't believe I did not cross paths with Dr. Noble at any point during my career so far. Let me share screen right now. All right, so I'm Jean-Nicolas. I go by JN. And this is sort of a talk very different than Dr. Noble's, and that's what makes this all wonderful about how I got to where I am. This is called alphabet soup because as you go on, whatever field, whatever direction you take, you add on, tack on all these letters to your name and all these titles. So I'm a PGY3 or postgraduate 3, third-year surgical resident in the Department of Otolaryngology, Head and Neck Surgery. That is ENT, in other words. At the same time, I'm trying to be a postdoctoral fellow in Dr. Kim's lab, and I'm presenting to you all today. So thanks for your attention. All right, part one, the ABCs. So how this all got started. I started in the NICU, very different than some of the children that Dr. Noble was talking about. I was just a precipitous or very fast delivery, but I was 10 pounds, so like the biggest baby in the NICU. This was in French Canada, and it was very cold. No one in my family actually was involved in any medicine growing up. This is my grandfather, and it was the most medically oriented picture I could find. He was a mechanic. My grandparents on the other side were factory workers, and my parents were the first to go to college. This is a picture of my brother and I in Belgium, and we moved to Belgium. And in this next picture, you can see my dad, who I look way too much alike now. My dad worked for the pharmaceutical industry, and so we sort of moved as he moved. We moved to Belgium, moved to France, lived abroad for a while before moving back to the United States. And this really changed a lot of things in my life, you know, my outlook on life, and I got very close to my brother. When I moved to the US, football was the biggest thing in my life, and it was, as were other team sports, through high school. Oops, I keep hitting the wrong button here. Along the way, I met a girl. Her name's Jessica, and she plays a critical part in this story. And again, just a reflection of how long all this training is. That dog, Wilbur, is no longer with us, but he was a good puppy. And here's another picture of my brother. So all this taken together, you know, I grew up with a faint interest in science, not knowing much about it, not knowing much about medicine. And for mostly athletic reasons, decided to attend AMHERST College. And I played football there. I was varsity football player for several years until I could no longer play for a variety of reasons. And that's when I had my first exposure to the lab. So I went straight, I just have a very addictive personality, went from being a gym rat to a lab rat. I worked with this awesome gentleman, Dr. Bishop, studying chemical biology and protein tyrosine phosphatases. This is a rough overview of the research as I go through this story. But essentially, I was doing a lot of chemical synthesis, a lot of very basic chemistry, basic biochemistry. And this was somewhat similar to the work my dad did, or I thought so, but nothing close to medicine. So after a couple summers at Amherst of doing this and getting close to graduation, not having the faintest clue what I wanted to do, I asked my father, you know, do you have some contacts from your, you know, your work in the pharmaceutical industry? Anybody more medical? Any, you know, could I see the other side of this story? And so I spent a summer at UPENN with this goofball, Dr. EL-DEIRY. He is an MD-PhD, and he is one of the all-time classic 80-20 MD-PhDs, 80% in the lab, 20% clinical. He's a medical oncologist, and following him that summer, shadowing him, seeing patients and doing some cancer work in his lab really changed my outlook on things. I met with some folks at UPENN Always encourage you to meet with folks, talk to people, who began and sort of planted the idea of an MD PhD in my mind. Amherst College is a good school, but I was not a good student. And so I took a couple years off to strengthen my CV, and made sure I could apply and succeed in getting into an MD PhD program, which I was sold on at this point. I continued working with Dr. EL-DEIRY for a couple years. And at this point, he was no longer at UPenn, he was at Penn State. And so Jessica and I moved in together in the middle of nowhere, Hershey, Pennsylvania. It was great. And some of the work I did in his lab, again, just talking about timelines and whatnot. This was in 2010, and we were studying quinacrine and 5-fluorouracil as anti-cancer agents, and clinical trial just wrapped up this year, 11 years later. So it does take quite some time. Somehow the Vanderbilt MD PhD decided to accept me. Grave mistake, but here I am. And this is the next part of my talk is about EGFRs, some more alphabet soup. I rotated in a variety of labs here on campus until I met this wonderful human being, Christine Lovely. She's still here in Preston Research Building, where I am on the 6th floor. She studies lung cancer. And what was really appealing about her research is that it was very human-centered, very patient-focused, highly translational. And so just to recap sort of the story up to this point, I was doing basic chemistry, oncology, cancer research, lab experiments, and now we're really doing research with patients and human beings, and it is really exciting to me. So I just thought I'd share a little vignette which kind of summarizes my PhD and the research I did and what I want to do moving forward. And I've dumbed this down, kind of de-identified it, dumb it down, wrong word, simplified things so that everyone can follow along. So most of my PhD was focused on this patient, just a healthy 33-year-old guy who had never smoked in his life, actually was an orthodontist, had 4 kids, and he came to medical attention with several months of coughing and hemoptysis, which is coughing up blood. He had extensive workup in December 2013 and a biopsy, and he had lung cancer. And this is unusual for, such a young man at this age. And, you always associate lung cancer with smoking. So something was going on here. His tumor was sent for sequencing of common mutations. Oftentimes you'd think, folks like this have some sort of genetic syndrome or their tumor has some sort of genetic mutation, but this was not the case. And so he just underwent standard chemotherapy. So 33-year-old guy on chemotherapy, losing his hair, just miserable, miserable situation. And of course, as you all probably know, lung cancer is a bad actor. And so in, 6 months after completion of therapy, 1 year after his diagnosis, he's relapsing. And so what can we do for this individual? Well, on the flip side, this is his clinical story. In the lab, we were working hard to figure out what was going on with this guy. We were looking for molecular alterations by a variety of platforms. So sequencing his tumor, doing DNA sequencing, hybrid capture-based arrays, until we sent it off to some smart folks at Foundation Medicine who identified a mutation using their genetic sequencing platform that would not have been picked up any other way, an EGFR duplication. So to summarize a PhD, essentially, as this man is undergoing chemotherapy, I am working my butt off in the lab, highly motivated by this human subjects-based research, modeling this protein, trying to determine how this protein works and whether we can drug it. And so we do cell-based models, we do models based on his own tumor, and we find that a particular drug named afatinib is particularly effective against this mutation. And so in meeting back the stories, we're now in November 2014. And you're looking on the left at a CT scan of this gentleman's chest. And if you've never seen a CT scan, it's essentially a bread slice through the human body. You are seeing the patient, left is right, right is left, as if they're laying down. So this is the vertebral column, the liver, and this chunk right here is a tumor. And this is when he had progressed or regressed. We were able to get companies to pay for FATNIB, and we're able to provide him with significant benefit. As you can see, just you don't need to be a radiologist to see tumor shrinkage right there, and several additional months of life. And this was really exciting work, really impactful, meaningful work for me, and something that I wanted to make part of my career. I had started the MD-PhD wanting to be a medical oncologist, wanting to be just like Dr. EL-DEIRY. And after spending time with Dr. Lovely, I wanted to do just the same. But during my PhD, though, I spent time with medical oncologists, and I realized it may not be the thing for me. I'm really hands-on, I'm very competitive. And so I started looking at surgical subspecialties, and again, exploring things. And so I spent some time shadowing all types of cancer surgeons. I really liked cancer. I thought that'd be a backbone of my career. So I shadowed neurosurgeons who took out brain tumors. I shadowed gynecologic oncologists who took out pelvic tumors, urologists, surgical oncologists who take out belly tumors, until I ended up in something I would have never expected, which is otolaryngology. So ENTs. So I'm an ear, nose, and throat doctor, but what we do is probably a lot more different than what you imagine. The first person I met in this field was Dr. Rodi. She is an awesome human being. Not sure you all ever see her around campus. But cancer surgery in the head and neck is very complicated. And I don't think as an undergraduate I was ever exposed to it. I don't think as a medical student I would have been exposed to it had I not sought out these opportunities during my PhD. So for example, I had some real pictures. I tried to tone it down with the diagram here, but if someone has a cancer of the jaw or the mandible, that needs to come out, as does part of the tongue, part of the floor or mouth, part of the jaw itself. These are huge operations. People's whole faces are, opened up, and it creates giant holes in people's faces, which we fill with artificial tissues from the leg, from the arm, and transplant, auto transplant. They're 16-hour surgeries. They're fascinating. I was in love. This was crazy. I'd never seen anything like it. It was like Civil War surgery, and patients did well. And so I decided to go all into ENT. I applied for residency all over the country. With my training from here, I was in a good position to go many places, but I decided to stay here at Vanderbilt because I really want to make the research side of things happen, and I can talk about this some more. Just a little bit more about otolaryngology, because folks, like I said, don't get exposed to it. It's a surgical subspecialty. So your ear, nose, and throat surgeon doctor is a surgeon. They operate from pleura to dura. And so we do head and neck cancer surgery, sinus surgery, so everything through the nose, including all the way up to the pituitary gland, sort of like the Egyptian mummy approach. We do facial plastic surgery, so Botox, facelifts, that's in our specialty. Reconstructive surgery, if there are bad facial scars. Some of our surgeons are neurotologists, so they take out brain tumors through the ear canal. We have a whole pediatrics subspecialty that interfaces heavily with the NICU and does a lot of airway reconstruction. We do a lot of airway surgery in general, and then sleep surgery, which is a fascinating new branch of our specialty. So right now I'm in year 3 of a 5-year surgical residency, and I have very little research time. And so I just wanted to highlight what I'm doing with that time and how I'm approaching things, which is essentially just my decision because there's no set pathway. It's a choose your own adventure here. My current interest is in pediatric thyroid cancer. It's a completely different entity than adult thyroid cancer. As you can see on this graph, um, adult thyroid nodules or precancerous lesions are common, whereas they're rare in children. But when they are present in children, they're much more likely to be malignant or cancer. Um, and the frequency at which this is happening in children is increasing, and it's unclear why. Um, it's also unclear what gene rearrangements or what point mutations are causing cancer in children. But regardless, they're taken out of thyroid, which is the definitive treatment, is much more complicated in children. So as I've been going through residency, like Dr. Noble said, it's very hard to make time for research. But what I can do is dry lab or computer research. And so we started looking at all the kids who had undergone a thyroidectomy at Vanderbilt for the past 15 years and at factors that could potentially predict malignancy. And we found that BMIZ score, which is essentially your BMI, can predict malignancy independent of any other factor. And this is cool and it makes sense, right? The rates of BMI in children keep going up. You hear about the obesity epidemic. And we believe it is causing a parallel rise in pediatric thyroid cancer. Why this is happening, I don't know. And this is definitely leaves a lot of room for basic lab questions, which I hope to be able to answer at some point. So goal and going forward, I want to end up as a head and neck surgeon scientist with a focus on rare tumors. Just going back to my PhD, just really interfacing with patients and the lab and taking things back and forth. I'm working on a variety of clinical genomics studies of rare tumors, including sequencing all the pediatric thyroid tumors we have on campus, laryngeal neuroendocrine tumors, all these things that are quite rare, but that we're fortunate to see here at Vanderbilt. And then just leveraging all the bioinformatical informatics that we have here at Vanderbilt. One of the reasons I wanted to stay was to leverage BioVU, leverage these large data sets that Dr. Kim has in his lab. And so that's what I'm doing. Putting together this talk, I thought of, finishing with all the people who've helped or whatnot. And then I remembered an 8th grade history teacher of mine had these things called tasty morsels instead of pearls. They're just little lessons. And these are mine, and they're by no means recommendations. It's just how I got to where I am. As you can tell in my PhD, I explored before committing to a clinical course, right? I looked at all these different surgical specialties until I found my people, which were the otolaryngologists. But once I was there, I committed. I put on the blinkers, which are your horse blinders, and I was just all in. And I think that really helps with a variety of different things. It'll seem like the grass is greener on the other side of the fence. There's a lot of FOMO, fear of missing out or whatnot. I think at the end of the day, the grass is just greenest where you water it. I think Megan's on this phone call, or folks from the MPV PhD know that I will push boundaries and break things. And I think that's what you need to succeed in a field like this, where the boundaries are not well defined. And so you have to sort of make things up as you go. Dr. Dermody, our former MD PhD director, used to say it's easier to ask for forgiveness than permission. So again, push the boundaries, get to where you want to go. And I put a lot of pictures throughout this talk and talk about people a lot, because this is ultimately like a very human enterprise. Like science tries to be very objective, but you're dealing with people, and in medicine, you're dealing with people. And I think regardless which way you go, you have to recognize that, understand it, and master it. And you rely on other people in order to get anywhere in these fields. And it takes a village of mentors, and it takes a village at home. And this is my little village. So that girl from earlier, I end up marrying her. Her name's Jessica. She's my wife. And these are my 2 awesome little kids, Arthur and Brigitte. And they help ground me as I do all this ridiculous stuff at the hospital, like take out half a person's face for cancer. I'm going to leave it on this last slide. Feel free to reach out to me. These are my emails, my phone number, and then I'm putting the HeadMirror website is a great website if you have no idea what otolaryngology is or want to look into it, and then just a link to the Kim Lab. I'll take any questions or whatnot. Happy to keep chatting and take this offline.
Thank you so much. I really appreciate that talk. That was really insightful and inspiring. I wrote down the grass is greenest where you water it. I need that. That's gonna stick with me for a long, long time. I'm sure we'll have some questions. Before that comes, I'll ask a scientific one, which I usually don't. So the correlation between BMI and thyroid or nodule prevalence, do you think that's a cause-effect thing, or do you think there could be something else like diet that impacts both of those?
We that's a good point. We normalized for everything we could find in the medical record, right? So socioeconomic status, which is linked to diet heavily, so that had no effect. Is purely, we did not control for diet specifically. My personal hypothesis and what I want to test in the lab is whether an estrogen load has an effect, right? So your adipocytes make estrogen, thyroid cancer occurs mostly in women. And so I wonder if there's a pathway there that could be actionable.
Fascinating. Someone just asked if you could go back to your golden nuggets, or what did you
Oh, my
call it?
family?
Morsel. Oh.
Yeah, tasty morsels.
That's wonderful.
Yeah, and this is just what has worked for me. And again, as opposed to pediatrics like Dr. Noble was talking about, or many other residencies, there's no path for research here, right? So I just sort of have to be a bull in a china shop and make it happen and have people notice me and help me and support me.
So is there not a PSTP resident?
There is not. A few programs have a year or two for research, but they are not nearly as well integrated as a PSTP. There's very few surgeon scientists in otolaryngology, which I see as an opportunity, but it's tough to get there.
I've heard that in general, surgery and the MD-PhD path just usually doesn't happen much. Is that true? And you just
I think it's partly a time thing. So head and neck surgery, for example, which is my field and I can comment on, takes a lot of skill, a lot of surgical skill to do those big operations, to dissect the neck, to, preserve the nerves, take out the cancer and whatnot. And that'll require about half your week just to keep up those skills. And again, I keep referencing Dr. Noble because she just spoke, but she was talking, the 80-20, 80% research, 20% clinical. That would not work with surgery because, you cannot do surgery one day a week. You would need surgery one day a week plus a day of clinic. And so you're already at almost, 40-60 or 50-50. And that's why it's tough. You're compressing your research time, you're compressing your clinical time, and have to excel at both.
Do you see staying computational, or do you see having a wet lab component to what you do?
I want to do both, right? So right now I'm working in Dr. Kim's lab, learning single cell RNA sequencing. The idea would be big data for hypothesis generation and then testing it in the wet lab. Because I think ultimately I love Westerns and cell culture and whatnot.
Wonderful. All right. Any other questions from anybody? I don't want to stifle anybody. Well, I just want to thank you both so much. This has just been a really insightful series to hear your paths. And one of the big messages in creating this that I wanted to get across is there's not a path. There's not a uniform path. And regardless, our series is for PhD, MD, and MD PhD. And kind of that's a running line is there's not one type of person that does this. There's not one path that's carved out for you to follow. And you guys really, really demonstrated that perfectly. I appreciate you both being here so much. Thank you.
Check out our website to find recordings of all of our videos. We'll get them posted about a week after each of the presentations. We can't wait to see you!